Time, a critical factor when called upon to establish a patent airway in a patient. When every second counts. The intubation process may be complicated by your patient's condition, either at the scene of a trauma or in an urgent hospital setting. A suspected cervical spine injury which may require special considerations. A facial gunshot wound. A trapped patient with limited access to the oral cavity. A cardiac or respiratory arrest patient with a compromised airway. Or any number of situations which may prevent rapid access to the airway for intubation with an endotracheal tube. The Combitube esophageal tracheal airway offers you a valuable tool for establishing an airway, quickly and efficiently, without the use of a laryngoscope. Designed primarily for esophageal placement, the Combitube will work equally well when placed in the trachea. Two sizes of the Combitube airway are available. The standard Combitube for patients over 5 feet tall, and the Combitube SA for those patients between 4 and 5.5 feet tall. Clinical experience has shown that there is a functional overlap between the two products, with either tube working equally well for patients between 5 and 5.5 feet tall. The Combitube airway is double lumen, meaning there are two pathways or channels for air to be delivered to the patient. The esophageal lumen with the blue extension tube is marked with the inscription number 1. This lumen will be the primary ventilation lumen when resuscitation or ventilation is begun after esophageal placement. The tracheal lumen with a clear extension tube is marked with the inscription number 2. This lumen is the ventilation lumen used when a tracheal placement has been accomplished. There are two cuffs or balloons on the Combitube airway. The large flesh-colored latex cuff is designed to seal the hypopharyngeal area. A large syringe with a blue color-coded tip and the plunger pre-drawn with the correct volume of air is provided to facilitate rapid inflation. The blue color-coded pilot balloon in communication with the latex cuff is marked number 1, indicating it is the first cuff to be inflated. When inflated, the cuff moves the soft palate dorsocranially, sealing off the nasal passages. The cuff anchors at the base of the tongue, fixing the tube firmly in the mouth and reducing the potential of the Combitube being extubated. Additional air may be added to the latex cuff if an incomplete seal is detected during ventilation. The distal or white cuff typically seals the esophagus to reduce the risk of stomach contents being aspirated. A pre-drawn syringe is provided to fill the cuff via the white pilot balloon marked number 2. If additional air is required to seal the esophagus, simply inject additional air through the number 2 pilot balloon. A suction catheter is also provided to decompress or suction the stomach after the airway has been established. Prior to insertion, it is advisable to oxygenate the patient for approximately 1 to 2 minutes, during which time the cuff integrity can be tested. When trauma has resulted in sharp broken teeth, bony structures, or dental appliances, remove the debris and exercise extreme caution when passing the Combitube into the mouth to prevent the cuffs from tearing. Intubation with the Combitube is accomplished rapidly and efficiently without the use of a laryngoscope. With the head in the neutral position, the Combitube is placed blindly into the patient. The two black rings on the body of the Combitube act as landmarks. The tube should be inserted until the teeth or alveolar ridges lie between these two black rings. Do not force the Combitube. If the tube does not advance easily, redirect it or withdraw and begin again. Once the Combitube airway is in place, inflate the latex cuff with air from the large color-coded blue-tip syringe supplied in the kit through the blue pilot balloon marked number 1. You may notice the Combitube moving slightly out of the patient's mouth. This is normal and to be expected. You have now sealed the hypopharyngeal area. Through the white pilot balloon marked number 2, inflate the distal cuff with air from the smaller pre-drawn syringe provided. The lower esophageal cuff is now filled and seals the esophagus. Air cannot pass into the stomach, being blocked by the esophageal cuff. Likewise, it cannot escape through the mouth or nasal passages, being blocked by the pharyngeal balloon. The gas or air from the delivery source is now traveling down the number 1 lumen, through the series of 8 ventilating eyes, over the epiglottis, and down the trachea. The Combitube will usually be placed blindly in the esophagus. Begin ventilation by placing the bag valve or ventilator circuit on the number 1 or longer blue extension. Auscultate both lung fields and abdomen to verify tube placement. Occasionally, but infrequently, the blind placement of the Combitube will be directed into the trachea. After listening for bilateral chest sounds and hearing no response, the resuscitation bag or ventilation circuit should be moved to the number 2 lumen and ventilation resumed. Again, listen for bilateral chest sounds. The Combitube is now functioning like an endotracheal tube. Air is moving down the number 2 lumen and exiting directly into the trachea and lungs. In the rare instance where no lung or gastric sounds are heard, deflate the cuffs, withdraw the Combitube about 3 centimeters, and reinflate both cuffs with the volume of air marked on the pilot balloon. This should reposition the Combitube airway correctly. Begin ventilation through the longer number 1 lumen. After insertion, cuff integrity can be verified by placing the pilot balloons between the thumb and index finger. Compress and release rapidly. The pilot balloon should fill rapidly, indicating adequate sealing pressure. If the pilot balloon responds slowly, it may be an indication there is insufficient pressure in the cuff to seal the corresponding area. Additional air should be added as required. While the Combitube may be left in place for prolonged ventilation, even in the esophageal position, some clinicians may wish to substitute a standard endotracheal tube for lengthy ventilation. This can be accomplished with the Combitube airway in place by completely deflating the large latex cuff through the number 1 pilot balloon. Move the Combitube to the left side of the mouth. Insert the laryngoscope, visualize the cords, and intubate with the appropriate size endotracheal tube. With the endotube in place and ensuring the maintenance of a patent airway, deflate the distal or esophageal cuff and carefully remove the Combitube airway. Alternately, if the cords cannot be visualized, decompress or suction the stomach. Then remove the air from both the esophageal and pharyngeal cuffs. Carefully remove the Combitube. Re-establish the airway with an endotracheal tube using approved intubation procedures. If you wish to exchange a Combitube placed in the tracheal position for a standard endotracheal tube, use a tracheal tube exchanger, following standard practices and protocols. Contraindications for use of the Combitube airway include responsive patients with an intact gag reflex, patients with known esophageal disease, and patients who have ingested caustic substances. The Combitube SA should be used for those patients from 4 to 5.5 feet tall, and the standard Combitube for patients over 5 feet tall. Either product may be used on patients between 5 and 5.5 feet tall, depending on the practitioner's judgment or governing protocol. The Combitube and Combitube SA are valuable adjuncts when the establishment of an airway cannot be accomplished by usual endotracheal means.